My name's Karen Sanders and I'm the Child Manager at the MRC-CTU for the STAMPEDE trial. In this presentation, I'm going to focus on some of the key issues involved in the treatment and management of STAMPEDE patients. So once an eligible patient has been identified and randomised, they should begin treatment as soon as possible. So starting with the hormone therapy. All patients on STAMPEDE will receive hormone therapy. The hormone therapy given can be in the form of the standard local practice, so either by treatment with LHRH analogues, orchidectomy, or for M0 patients, anti-androgens alone can be used. So moving on to the zoledronic acid, and there are a number of measurements that should be taken before the administration of zoledronic acid. Serum creatinine must be measured within 48 hours of each zoledronic acid infusion. In addition, serum electrolytes must be measured before each infusion. And finally, a full blood count must be taken every 3 months. So on to the administration of the zoledronic acid. The treatment schedule is as follows. Patients receive a 15-minute infusion of 4 mg of zoledronic acid every 3 weeks for 6 treatment cycles. Following this, patients should receive the 4 mg infusions every 4 weeks, up to a maximum of 2 years or until disease progression. And in addition to this, patients who are receiving zoledronic acid should also receive a daily oral supplement of calcium and vitamin D. So in regard to dose modifications for zoledronic acid, if there's evidence of hypersensitivity to zoledronic acid, then it should be immediately discontinued. And in addition, patients receiving zoledronic acid should have their renal function closely monitored. The table on the slide gives details of the required dose modifications, but for further information please refer to Appendix F of the protocol. And finally, in regard to zoledronic acid, the summary of product characteristics for zoledronic acid was recently updated, and there has been some rare reports of cases of osteonecrosis of the jaw following zoledronic acid administration, and this has been a particular problem following major dental extractions, and so investigators should be aware that patients who are likely to require major dental extractions during the period of zoledronic acid treatment are unlikely to be suitable for STAMPEDE. But if you have any concerns about dental treatment for any current or potential STAMPEDE patients, then please contact the MRC-CTU to discuss. So on to the Docetaxel. The STAMPEDE protocol in Appendix F gives details of a suggested pre-administration regimen for Docetaxel, but it's important to note that this is meant as a guideline and that local practice can be used if preferred. So the Docetaxel treatment schedule is as follows. Patients should be given 75 mg per metre squared as an IV infusion over 1 hour, and in addition they should be receiving 5 mg of prednisolone twice a day for the whole 21-day cycle. The treatment should be given every 3 weeks for a maximum of 6 cycles. So in regard to dose modifications for Docetaxel, if possible, toxicities that occur due to Docetaxel use should be managed symptomatically. If it's felt that toxicity requires a dose reduction, then this should occur as shown here. But once a dose reduction for toxicity has occurred, then the dose can't be re-escalated even if the toxicity is resolved. And finally on to the celecoxib. The celecoxib treatment schedule is as follows. Patients should receive 400 mg of celecoxib twice a day. The celecoxib in STAMPEDE comes in the form of 200 mg capsules, and therefore the patient should take 2 capsules twice a day. Treatment with celecoxib should be for a maximum of 1 year. So that concludes the summary of information about the treatment and management of STAMPEDE patients. If you have any queries or would like any further information, then please do not hesitate to contact us at the MRC-CTU.